My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Hello and welcome to COEG Conversations, an educational series sponsored by Biomedica Diagnostics of Windsor, Nova Scotia, Canada. Our topic for this series is immune thrombocytopenic purpura, ITP, and the inherited platelet function disorders. I'm George Fritzma, faculty of the University of Alabama at Birmingham Division of Laboratory Medicine and proprietor of the Fritzma Factor, your interactive hemostasis resource. It's my privilege to introduce our guest, Dr. Michele Lambert. Dr. Lambert received her undergraduate degree in biology from Rensselaer Polytechnic Institute and attended medical school at Rutgers University. She did her residency in pediatrics at St. Christopher's Hospital for Children in Philadelphia, followed by a year as chief resident and then hematology oncology fellow at the Children's Hospital of Philadelphia, often shortened to CHOP. She is now an associate professor of pediatrics in the Perelman School of Medicine at the University of Pennsylvania and a pediatric hematologist at CHOP, where she is the clinical director of the Special Coagulation Laboratory and co-director of the Frontier Program in Immune Dysregulation, as well as the director of the CHOP Pediatric Platelet Disorder Program. Her particular clinical interest is in the inherited and acquired platelet disorders and in the interplay between genetics and disease. Her current research focuses on understanding the role of genetics in this space. She is a member of the ClinGen Hemostasis and Thrombosis Clinical Domain Working Group and a co-chair of the ClinGen Hemostasis and Thrombosis Gene Curation Expert Panel, as well as the past chair of the Pediatric ITP Consortium of North America. By understanding the drivers of differences in biology in platelet disorders, Dr. Lambert hopes to develop targeted therapies to improve outcomes. We now begin the second conversation with a discussion of the laboratory diagnosis and management of ITP. Welcome back, Dr. Lambert. Let's start with the question, how do we diagnose ITP?
Thanks for that question. So ITP is a diagnosis of exclusion, meaning that I don't have a test that I can send and say, oh, your test shows you have ITP. I set this test and you have ITP. So what we usually do is get a good history, do a thorough exam, get a family history because the family history can be quite contributory, and then get a blood count and, importantly, review the peripheral smear of that patient. And then once we've done those things, if we don't have any other clear and obvious reason for the thrombocytopenia, then we essentially assume that it's immune thrombocytopenia. And there are some things that might make us think that it's more likely to be immune thrombocytopenia based on history or exam or something like that. But But in general, if we don't find something else, then it's probably immune thrombocytopenia.
But we in the lab all offer an antibody test to see if those antibodies or autoantibodies are there. How about those tests?
Yeah, I mean, antibody testing in ITP is a thing that has been in development for a really long time. And I admit that we have antiplatelet antibody testing available too. And I don't use it very often. I think that in the majority of patients, either I'm pretty sure they have ITP and I don't need the test, or I don't think they have ITP and it's not going to help me. There was a very nice, actually recent review and meta-analysis of all of the published literature up until 2019 of the different antiplatelet antibody testing that's been published, that actually showed that the specificity is pretty good, actually, but the sensitivity is not good at all. So if you have a positive antiplatelet antibody test, that helps you to say, yes, that patient might have ITP. But if you have a negative antiplatelet antibody test, that actually doesn't help you at all. It's about 50-50 whether or not that patient has ITP. And that's the patient in whom I actually think I probably need it the most, is where, I'm really not sure. And that's when I want the antibody test to be positive or negative. And then, so if it's positive, that might help me. But if it's negative, that actually doesn't tell me anything. And so I think for that reason, I often don't send antiplatelet antibody testing.
So the lab's contribution is fairly small then, mostly just getting a platelet count. And does it help to have what we call the differential count, or looking at the lab film and looking at the morphology of the platelets?
Yeah, the smear is really important, actually, and the differential is important. So I think both of those things are critical. Ideally, we look at the smear ourselves, but not everybody is able to do that. And now, especially in the US, with insurance companies dictating where patients are allowed to have their labs drawn, it has to go to Quest or LabCorp or whatever. It becomes even more important that that smear that patient has a differential, and that smear is reviewed by somebody who knows how to look at a peripheral smear and can actually identify things that would be important to know. Are there schistocytes on the smear? Are there abnormal white blood cell characteristics? For example, are there Dolly bodies in the white blood cells? Are there abnormal white blood cells at all? Is the red blood cell morphology normal? So not just schistocytes, but is there reticulocytosis? Are the red blood cells big, or are they normal size? And are the platelets normal appearing? Do they have all the granules they're supposed to have? Or are they small, or are they big? And in ITP, you really actually should have some big platelets and some normal sized platelets. Probably shouldn't have too many very small platelets. And you probably, and you wouldn't expect to have all giant platelets. So if you have like all of the platelets are giant, or all of the platelets are really small, that's probably not ITP either.
Well, this makes me feel good, all those years doing differentials, and now the instruments are just counting them for you. But it seems like those counts can't find all of those details.
Yeah, I think it's still important to have somebody take a look at the smear and really look at what those cells look like under the microscope.
Talk a little bit about the differential diagnosis. How do we separate ITP from, or what are the other things that come close that you can confuse ITP with other diagnoses?
Well, so there are a couple of inherited platelet disorders that are not infrequently misdiagnosed as ITP. And so it's important to be able to differentiate those. For example, I have certainly seen patients who are misdiagnosed who actually have MYH9 related thrombocytopenia. So a macrothrombocytopenia that may or may not be related to other problems like renal disease, cataracts, and hearing loss. I have seen patients who actually have Bernard-Soulier syndrome, either monoallelic, which tends to be much more mild and less of a bleeding disorder and more of a macrothrombocytopenia, or biallelic, true autosomal recessive Bernard-Soulier syndrome, which is a pretty significant inherited bleeding disorder, but misdiagnosed as ITP with bleeding that's out of proportion to that low platelet count. And there's certainly literature also to support patients who have RUNX1 mutations or ETV6 mutations. These inherited platelet disorders can have normal sized platelets and have a platelet count that's variably low. And so they can also be misdiagnosed as ITP. And there may not be family history in any of those platelet disorders. And so just because you don't have a family history of thrombocytopenia doesn't mean you don't have an inherited platelet disorder. Just because the first time somebody noticed that your platelet count was low is when you were an adult doesn't mean that you didn't have that low platelet count even from childhood. And so I think it's really important to make sure that you look at the smear and look at all those other things, look at the rest of the CBC. And if your patient has macrocytosis or a macrocytic anemia, they probably don't just have ITP. There's something else going on, and thinking about all those other things. There's other things to consider.
And you mentioned schistocytes. Is microangiopathic anemia part of the possibilities?
Yeah, so those are the inherited thrombocytopenias, and then there's other acquired thrombocytopenias. So there's drug-induced thrombocytopenia, there's viral-induced thrombocytopenias, there's acquired thrombocytopenia from like a TMA, thrombotic microangiopathy. So you want to make sure you don't have schistocytes on the smear, and or evidence of hemolytic anemia. And I certainly have seen patients who have this sort of low-grade anemia and reticulocytosis and thrombocytopenia, and somebody thought that they had Evans syndrome, and then it turned out actually that they had a TMA. The other thing to consider as well is you can have ITP, immune thrombocytopenia, and it might be primary. It might just be that you only have immune thrombocytopenia, but you might have immune thrombocytopenia because you have lupus or because you have CVID or common variable immunodeficiency, or because you have some other immune disorder. And it's important to consider those diagnoses as well, because you certainly don't want to take the spleen of somebody who's immune deficient out as their treatment for their spleen, as their treatment for their ITP, and make their immune deficiency worse.
Now, with all of this, how is ITP managed currently, and what's the contribution of the lab in managing the disorder?
Well, so I think the contribution of the lab in managing the disorder is helping to establish that it's the correct diagnosis. So helping to evaluate all the other things that it could be. So viral testing and, testing for an ANA and other autoantibodies, testing for lymphocyte subsets and immunoglobulin levels in the appropriate patient where you suspect that something else might be going on. Monitoring those things if you suspect that there's some other underlying diagnosis or driver of the ITP. And then for monitoring patients who are on therapy, because we have so many different options now, or even choosing a therapy, you might want to send a thrombopoietin level, for example, to help determine whether or not your patient might respond to a TPO receptor agonist. Because there's some emerging data now that suggests that if your TPO level is really high, you may not respond as well, or you might need to start at a higher dose. Or, for example, if you had somebody who had a really low immunoglobulin level to begin with, you might consider what therapy you might want to give, and you might think about, does this patient actually have CVID? Maybe I don't want to do a splenectomy in this patient. That sort of thing.
Talk a little bit about the TPO receptor agonists. It looks like that's kind of an emerging therapy. And also, they're using any of the anti-complement therapies?
Yeah, so the TPO receptor agonists are, I think they're more than an emerging therapy. I think at this point, the TPO receptor agonists have moved to being not quite first line, because they aren't technically approved for use in newly diagnosed patients with ITP, but they have moved up to being used quite early on in adult patients where you know it's going to be a chronic disease. So if you have a patient where you really establish the diagnosis, and you know that they have a drop in platelet count when you try to take them off the steroids, I think providers on the adult side are really moving pretty quickly to TPO receptor agonists. On the pediatric side, we are still mostly doing observation for our newly diagnosed patients who are not having significant bleeding symptoms, but we are definitely moving towards using the TPO receptor agonists at that like 3 to 6 month mark if somebody still has ITP and we're restricting activities, or there's a lot of anxiety around the platelet counts, or a lot of lab monitoring of platelet counts that's happening. We try not to focus in the pediatric world so much on what the number is and more on bleeding symptoms for monitoring. But I think it's hard for people to get away from that number, to be like, you mean you don't want to know what the platelet count is at all? It doesn't matter. It's hard to make that shift. And a lot of providers and parents really want to know, what is my platelet count? And really try to make a lot of decisions around that number.
Even though symptoms may vary, while platelet counts are not necessarily aligned with the symptoms.
Correct. Yeah. Even, I mean, I've certainly seen children whose platelet counts are 7, 6, 3, and no bleeding symptoms. And then I have taken care of patients whose platelet counts are, 15, 18,000, and they have significant nosebleeds and gum bleeding. And I'm like, we have to intervene. We can't leave this platelet count here.
Are there any new lab assays and management approaches that are coming in the future? I know your lab seems to be quite advanced where you are. Are some new things that you're trying?
Well, I'll say that there are definitely people that are using things like the immature platelet fraction or reticulated platelet counts. Reticulated platelet counts are hard to get, but the immature platelet fraction's available in a lot of places now. And I think more commonly used in pediatrics than in adults to help to establish the diagnosis, and also to help to decide about bleeding risk. So if I see a patient who I suspect has ITP and their platelet count is 10,000 and they have an immature platelet fraction of 12 or 13%, I actually am pretty comfortable leaving them alone and not intervening for that platelet count. But if their immature platelet fraction is only 3%, I worry about their risk of bleeding a little bit more. And I question the diagnosis in that setting. And I wonder if I have the right diagnosis. And so I think there are other providers who feel the same way, certainly on the pediatric side. I think it's moved less into the adult side, but it's starting to be used a little bit on that side as well. And I think it can be helpful. As far as other laboratory assays, there are assays we can use to look for TMA that people are using. Certainly ADAMTS13 testing is really becoming a lot more available and more easily obtainable with a faster turnaround time. The terminal complement activation complex, the membrane activation complex, or soluble C5b9 assays to look for complement activation are certainly much more available now as well. So if you really think TMA is on the differential, it's pretty easy to get those assays now and in a reasonable time frame. So I think it's easier to rule those things out than it ever was before. TPO levels are easier to get. Flow cytometry is starting to be easier to get, I think, too. And so I think maybe over the next 10 years, we'll maybe have more testing that we can do to help put patients into buckets and say, you're at risk for bleeding, you need to be treated. You're at lower risk for bleeding, you don't need to be treated. But if we do treat you, this treatment is probably the best option for you.
Well, it's comforting to me when back when I was still working in the lab, we had instruments that gave you immature reticulocyte fraction and also mean platelet volume, MPV. And I always used to be happy to report those to the physicians, and I could tell that they were just being polite.
I use them. I use the immature reticulocyte fraction a lot more in my sickle cell patients than I use it in my ITP patients, but I use the IPF all the time in my ITP patients, and I use the mean platelet volume in all of my thrombocytopenic patients. And if the lab can't give me an MPV, I definitely want to see that smear, because there's either a lot of variation in that mean platelet volume or it's really high. That's what that means if they can't give it to me. And so I need to know why they can't give it to me.
Well, that makes me feel so much better. Thank you. Is there anything else that you'd like to say about the lab and association with the therapeutics that you're using now?
No, I think the one other comment I'll just make is because you did ask about complement therapies, and
yes.
Those are new. We have immune-directed therapies that are emerging, and so there's SYK inhibitors, there are BTK inhibitors, there's rituximab, which decreases B cell activity. People are using other T cell modulators and stuff. But the complement inhibitors is a totally new way of looking at ITP and looking at whether or not that might be a pathway that's dysregulated in patients who have immune thrombocytopenia, but not TMA. And it was surprising to me to even see that there would be efficacy at all in that patient population. And it does appear that, blocking complement is at least as effective in the right patient as SYK inhibition and as BTK inhibition. So I think all the more reason that we really need to be better at figuring out what's happening in each patient and then targeting the therapies to the immune mechanism that's happening in that patient.
Well, it does seem like there is a lot of growth and a lot of value in what the lab is doing. I'm interested in how the ADAMTS13 assay is so readily available now. I know some of that was developed in your facility. I am acquainted with Dr. Long Zheng, and I know he was working on that there, and he was at UAB for a while as well, and has done a lot of work with the Adams TS13, including the product, the Adam TS13 product.
Mm-hmm. Yeah, I don't actually know how much he was involved directly in the assays that are currently clinically available. The turnaround times vary considerably for that assay, but it certainly in the last 5 years for sure has become much more widely available. And there are labs that can turn it around in less than 24 hours if you call and ask for it to be turned around that quickly. So I think that it is possible to get an Adam TS13 back quickly. It's just a matter of whether or not you can get the specimen to the lab quickly and whether or not you can call and intervene and get it turned around that quickly. So not everybody can get one that quickly. But there are definitely places that are turning it around real fast.
That's a great development. There's many developments in this area, and it's very exciting to see it all happening.
Yeah, it's pretty cool.
Well, thank you. This concludes our second conversation. And Dr. Lambert, again, thank you for your expertise. We encourage participant questions and comments, and there's a link on the Biomedica Diagnostics website for you to download a transcript of today's talk, as well as to see the video and to forward your questions or comments. Please join us next month for conversation number 3, entitled The Inherited Platelet Function Disorders. Thanks to Biomedica Diagnostics for sponsoring COE Conversations, and thank you for your participation.